In this series, we are going to discuss deep vein thrombosis, or DVT, in detail. This can be appreciated in the schematic on the left-hand side of the presentation. However, as we move through this series, I would just like to emphasize here, right from the get-go, that really, when we are talking about DVT, our feared complication and all of the rationale behind our management is that we are trying to prevent this progression from a DVT to a PE, or pulmonary embolism. We will have a separate module on pulmonary embolisms, or PEs, but I would just like to state this framework up front, that when we are talking about DVTs, really what we fear most is that the patient will go on to develop a PE, as the morbidity and the mortality associated with PEs can be so devastating that really DVTs are essentially a clue to us as a precursor to the potential development of this deadly condition. Without further ado, let's delve into our classic presentation of a DVT, which will be swelling, erythema, warmth, and pain of the calf. Additionally, these patients will classically have a history that supports the Virchow's triad. We will cover this in more detail in the coming slides. DVTs most commonly will be unilateral. This is especially the case on examinations. However, in actual clinical practice, they can of course be bilateral. Because DVTs are usually going to be unilateral on your examinations, you should be able to appreciate a difference in the calf diameters, as the affected side is going to be more swollen than the other. Additionally, when there is a thrombosis in one of the deep veins, you can have dilation of some of the more superficial veins, as there is essentially a backup of blood, thus leading to a dilation of more superficial, more proximally located veins. Here we have an absolutely classic image of a DVT of this patient's right leg. This gives us an excellent comparison, allowing us to see some of the erythema, swelling, when compared to the unaffected left leg. And so this is an image that you really should be able to burn into your brain when it comes to DVTs. There are some subtle differences that are extremely important in high yield that we use to distinguish DVTs from cellulitis. Chief among them is the fact that in cellulitis, you should be able to get this well demarcated zone where you can very clearly tell where the cellulitis starts and where the cellulitis ends. This allows us to be able to monitor patients' response to therapy, and you will often see this used in the hospital where we will actually draw using a surgical marker along the borders where the cellulitis starts and where it begins. However, when you look at a patient with a DVT, it is far less clear where the DVT starts and where it begins. There is not this clear demarcation where there is erythema and then an absence of erythema, and therefore this is something to look out for on your examinations, as DVTs are not going to be as clearly demarcated clinically and on physical exam when compared to, for example, cellulitis. In exam vignettes, patients should have a history that suggests Virchow's triad. Virchow's triad consists of stasis, hypercoagulability, and endothelial damage. In stasis, the patient may have a history of a recent flight, a long drive. For example, the patient may be a truck driver as their profession, or the patient may have had a recent surgery, in which case they will be resting and not moving around very much, thus allowing this stasis to occur. In addition, there are several conditions which can predispose a patient to the development of DVTs by virtue of their increase in the patient's hypercoagulability. These include conditions such as factor V Leiden, which we discuss in more detail in our hematology-oncology modules, the use of oral contraceptives, or OCPs, which can lead to hypercoagulability, hormone replacement therapy, malignancy, and pregnancy. The third and final component of Virchow's triad is endothelial damage, and this includes things such as trauma or surgery, which can ultimately predispose the patient to the development of a clot. One classic physical exam finding that you will see with patients in DVT is known as the Hohmann sign, not to be confused with the Hamann sign, which is also extremely high yield for examination purposes. In the Hohmann sign, the patient is classically going to have pain on dorsiflexion or deep palpation of the calf, and this is highly characteristic of a DVT. This is in contrast to Hammersign, which refers to a crunching sound that is heard on auscultation that is synchronized with the patient's heartbeat. A Hammersign can be appreciated when there is the presence of free air in the mediastinum, as is the case in pneumomediastinum, as well as in various instances of tracheobronchial injury, including chest trauma or caustic ingestion. And therefore, Hammersign is what we would expect to see here, for example, in this patient on the right-hand side of the presentation, where you can see that we have some free air here present in the mediastinum. And so simply remember, moving forward, DVT, Hammersign, pneumomediastinum and tracheobronchial injury, Hammersign. Our first step in the workup and evaluation of a patient with a suspected DVT is first to determine their Wells score. This is essentially what allows us to determine the patient's pre-test probability of having a DVT, and we can achieve this using the modified Wells criteria, in which each criterion gives the patient either 1 point or takes away 2 points, as we will see as we move through this list. Just to go through each of these criteria briefly, if the patient has paralysis or recent casting of the lower extremity, this will give the patient 1 point. This is not surprising, as this represents the stasis component of Virchow's triad. Similarly, if the patient has been recently bedridden for at least 3 days, again, stasis of Virchow's triad, or has had major surgery in the past 4 weeks, then that patient also gets 1 point. The next several criteria of the modified Wells criteria are related to the patient's symptoms as well as our findings on physical exam. If the patient has tenderness in a deep vein, then they get 1 point. If they have swelling of an entire leg, they get 1 point. If they have calf swelling that is 3 centimeters greater on their affected leg when compared to the unaffected leg, then they get 1 point for this. If they have pitting edema that is greater than their affected leg, then they also get 1 point. And if they have collateral non-varicose superficial veins, then this also gives them 1 additional point. If the patient has had a malignancy within the last 6 months, then they get 1 point. This represents the hypercoagulability component of Virchow's triad. It is also important to note that if the patient has an alternative diagnosis that is more likely than DVT, then we subtract 2 points from their score. This is the case in, for example, a Baker's cyst, in which the patient may have swelling or tenderness of their leg, but ultimately there is an alternative diagnosis that is more likely. And lastly, if the patient has a history of DVT, then they also get 1 point. This is ultimately what distinguishes the modified Wells criteria from the original Wells criteria. As we stated previously, our diagnosis and workup of a DVT is going to be based on the pre-test probability, or PRP. This is what we determine using the modified Wells criteria, which generates a Wells score. If we have a modified Wells score that is less than or equal to 1, then the patient has a low pre-test probability of having a DVT. However, if the patient has a modified Wells score that is at least 2, then that patient has a high pre-test probability. For those who have a modified Wells score that is less than or equal to 1 and therefore have a low pretest probability, then we will get a D-dimer in those patients. This is because if that D-dimer is determined to be low, meaning less than 500 nanograms per milliliter, then that patient requires no further testing, as they are very unlikely to have a DVT. This is because the sensitivity of the D-dimer is quite high, and therefore if this D-dimer is low, then it is extremely unlikely that there is a DVT present. However, if the patient has a high pretest probability with a modified Wells score that is at least 2, or if they have an elevated D-dimer, then we need to get a compression ultrasound of the leg. If this ultrasound is positive for deep vein thrombosis, then we may begin anticoagulation therapy. We will discuss this in more detail in our management section. And if the ultrasound is negative, then a DVT is highly unlikely.